Now, just wanted to say I've just credit to Dr. May Duong, who's the Salin GPLO, who kindly contributed to this presentation, even though she's not here tonight. So our job was talking about mental health and physical health, and the job was all the things we don't think about, because of course we're all people who have our patients' care strongly at heart and we want to improve what we do. But I also wanted to acknowledge tonight that we are actually doing a lot, and to really acknowledge that GPs are working very hard for the physical health of our mental health patients, and that should be acknowledged. So if you could do the next slide for me, Nan, that would be great. So I particularly love this idea of embodied minds. As you all know, the mental and physical health of our patients is intimately linked. Both simple, can't separate them, we are both, but it's very complex because they're intricately intertwined. So we could write a PhD on this, but I wanted the presentation today to focus on very specific, practical, day-to-day strategies and practices, and just ways of thinking about things that keeps it interesting. And I also wanted to acknowledge that this sort of work is familiar GP specialist core business. So I want to avoid teaching my grandmother to suck eggs, as the saying goes, but hopefully we have some really good conversations about this. Next slide, please. So why is it so important? Again, preaching to the converted. We know that people with chronic mental health have greatly reduced life expectancy compared to non-affected peers. The biggest issues are cardiovascular disease and, of course, contributed to by smoking, physical activity, etc., which we're all very familiar with. Next slide, please. The relationship between physical health and mental health, of course, is a two-way street. Physical health issues of their own will also contribute to mental illness. You think of someone who perhaps has severe and chronic severe rheumatoid arthritis, it's completely expected that they may experience depression dealing with their very debilitating illness. So it's two-way. So of course, things that we address as GPs, lifestyle and self-care, there are aspects of self-medication and recreational drug use, both as just recreation as also as self-medication of its own. The side effects of specific medications. We know there are known vulnerabilities of specific psychiatric conditions and or physical conditions. So look at the link between schizophrenia and autoimmune disease. And then the aspect that I feel isn't often talked enough, but we're all very aware of, is the incidence of ACEs, or adverse childhood experiences, in our patients. Next slide, please. So ACEs, there's a landmark study back in the 90s and then a more recent Australian study, which I'll refer to. But I just want to everyone to take a moment now to take in mind the idea of self-care. We know 40% in the big studies of people have had at least one ACE. And in the Australian study more recently, 25% of people in very large numbers have 3 to 5 ACEs. So there's very likely an experience either personally or in a loved one. In caring for our patients with adverse, certainly the more severe ones, there's compassion fatigue and vulnerability to vicarious trauma. And I do highly recommend going to the website Numbers Story. Got some really nice resources for your patients who've experienced a very high load of ACEs. New slide, please. So what is that relationship? Why do I want everyone to keep ACEs in mind? Well, 4 or more ACEs in the original landmark 1998 study, 4 to 12 times the rates of alcoholism, drug abuse, depression, and suicide attempts, 2 to 4-fold increase in smoking, and 1.4 to 1.6 physical inactivity and severe obesity. So you can see how physical illness is core business for people with mental illness, and in anyone, whether they have developed a mental illness or not, if they've got a high level of childhood ACEs, they're at high risk regardless. New slide, please. So what was really good was that no one had actually revisited this work. So the Australian Child Maltreatment Study of 2023 looked at 10,000 Australians 16 and over, and the proportions are replicated. So this is a universal thing. So I'd like if there's one take-home message tonight, is to adopt a universal consideration, if you like, of ACEs in all your patients, whether they present with a mental illness or not. So 32% had physical abuse, 28% sexual abuse, 30% emotional abuse. So you can looking at those numbers, they're really high. And I think if you want one number to remember, 23%, 3 to 5 ACEs. And we know from previous studies that they're going to have a really high incidence of physical health issues over and above their higher incidence of mental health disorders. Next slide, please. So tonight I wanted to think about as we see our patients with mental health issues, our physical health care priorities in sort of 3 domains. So there's that preventative care or universal preventative care. The RACGP Red Book's a good example. We want to do that for all our patients, but we're really focused on catching those with additional genetic or environmental vulnerabilities or a current illness that's not yet formally diagnosed. So in preventative care, a blood pressure, just universal, covers so many things, particularly related to our patients on long-term antipsychotics and metabolic syndrome. Then the next idea is that specific care. So a lot of this talk tonight is about those special guidelines, you know, the clozapine pathways, metabolic stuff. There's a lot of really good step-by-step pathways that I won't bore you with tonight because you can go and look them up yourselves. And then the other thing I really wanted to acknowledge tonight is the idea of the complex care side of physical health care and mental health. And this is something really important and not often remembered. This is GP-led. The GP coordinates all of the above. You're coordinating, you're that home base for the patient for all the specialist treating teams, from the cardiologist to the psychiatrist. So I really want to applaud that, but also emphasise tonight this is our most important work for our mental health patients. Next slide, please. Okay, so one of my favourite topics is the overlap of psychological medicine with physical health care is in everything we do. So tonight, of course, our focus is the second example I give there, supporting and treating the compliant patient with schizophrenia who, despite a good illness response to their clozapine, disappointingly develops a severe leukopenia. So that physical health complications of treatment for their mental health issue. But I also want to argue this is as important when you're counselling and educating the non-compliant patient in the early stages of diabetes type 2, who's neglecting their own health care as carer to an elderly parent. So psychological medicine is in both of those equally, and attention to maintaining physical health as important for both. Next slide, please. Okay, so prevention. It's just easy. Nah, it ain't. No, it's complicated. I really like this slide, and I just wanted to say, GPs, we have to do everything. Really, we're doing a bit of primary, bit of secondary. We're often the missing middle. We're trying to link tertiary with primary. We're the advocate for getting patients in quaternary care, and basically keep on keeping on as far as that goes. And that's where simple systems like quarterly reviews for your mental health patients, where you can just get a blood pressure, not try and do crisis-centred management, try and get them into a routine of regular care, ensures their care's better and makes your life easier. Next slide, please. Okay, so again, that universal, everybody. So this is where many of you would already be doing this, but having a bit of a system and also getting the patient back regularly, e.g. quarterly, for growth, weight, cardiovascular, etc. I won't read all that, but they're really important. And probably the two that I have to remind myself to be very mindful of, because they very easily go on the back burner, is dental health and bone health. Making sure you got a vitamin D, at least exercise. And I would hate if I did an audit now of how with my patients I checked and had a dental check the last 12 months. I'm pretty sure it'll be pretty terrible. We're actually doing an audit for it this year for my points. Okay, next slide, please. Now, this is where tonight we wanted to make sure in the Q&A you could ask any questions you have about the specific care. So there are quite detailed and rigorous pathways. So we do have state guidelines on the care of metabolic syndrome. We do have special guidelines and supports we need for patients on clozapine who may develop life-threatening leukopenia or neutropenia. Patients on stimulant medication, that's increasingly with community awareness and a bit of the community playing catch up with children who missed assessments in childhood now getting diagnosed in adulthood. There's a real wave of that coming at the moment. And the importance of cardiovascular growth and nutrition checks in those patients is going to be very important and become a larger part of our work. A big issue I find, I see a lot of people with anxiety, is the tolerance and rebound symptomatology with benzodiazepine use. I don't actually see people at the beginning of that. Most people I see they're trying to get them off that end in my work. And of course, the fascinating areas of pain gating and nervous system changes in the chronic pain syndromes and the specific effects of long-term opiate use. And again, the very important area of osteoporosis. So we know osteoporosis is associated with quite high morbidity and mortality in the older age group, and very important to look at. And next slide, please. Now, my specific area of interest is children and young people. So I'd probably see a larger proportion of kids with anxiety, depression that complicates neurodevelopmental conditions like autism and ADHD. And I just wanted to remind you there's some really helpful guidelines if you have young patients. The good old Royal Children's Hospital in Melbourne has in their paediatric hypertension has a lovely little link, which you can see there in the blue-green, where you can plug in kids' blood pressures, and instead of having to look up the laborious charts that are blood pressure to height, centile, standardized, you can now just plug in to age, height, blood pressure, and it tells you if it's good or not and a pathway. So use that all the time. Highly recommend it. And there's just a little table here. I'm very happy for these slides to be provided, but it's very important not to forget in young people the effects of the disrupted neurovegetative features. They're very easy to forget. Effects on sleep, appetite, complex sleep, particularly complicated by screen use in young people, and associated lack of exercise, and you can get, vicious circle there. Very important in ADHD to check their putting on height. They can often appear to be okay and their weight's okay, but if they are not putting on height, that's really important that needs looking into. And of course, the very challenging area of patients with autism spectrum disorder who tend to have very restricted diets of white food and yet are on long-term low-dose antipsychotics for their very severe anxiety. So very high risk of metabolic syndrome and get issues such as hypercholesterolemia, hypertension, obesity, etc. Next slide, please. Now, this is a great slide, very small. I'm sorry about this. But there's a really nice article from Australian Prescriber looking at specific care for people with schizophrenia. And what I really like about this one is it really encourages that routine review, at least 6 monthly. Personally, I find if I do this stuff 6 monthly, it's massive. Some other crisis is happening at the same time, end up super long appointments. I've found my appointments much more manageable since I've made it routine minimum 3 monthly. And for some of my really complex patients, 6 weekly that's the thing. See in 6 weeks just becomes the new normal. Of course, that's the patients who have the wherewithal to come to those regular appointments. I know it can often be a struggle getting patients to come in, but that's a whole nother line of conversation perhaps we can address in the Q&A. Next slide, please. Okay, so just a brief mention. I'm not going to go into super detail, but Jackie, I will invite you to talk around clozapine as someone who does a lot more of the adult work than I do. So we do have some really good resources here on the SA Health website, and I would strongly invite you to have a look at those, get your head around those. I'd imagine people of you who have patients on regular clozapine are all over these. I think it's really good if we're all aware of what's required, and in the event you have a patient new to it, you're not going to be feeling quite so out of your depth. Next slide, please. Jackie, did you want to say anything about clozapine before I moved on to metabolic health?
Oh, yes, please.
Yeah, you would.
What,
Go
lots,
ahead.
lots of things to say about clozapine. But one of the really important points that I want to bring out tonight, because it fits with the other preventive health that you're talking about, is clozapine and smoking. And it's really interesting how people don't, and I'm going to give a little example. We had a patient in our hospital avoidance supported discharge service fairly recently, and the physician who was seeing him came to me and said, "Oh, look, I've got this person on clozapine. I just wanted to check, is there any interaction between the stop smoking, the smoking cessation agent that he's taking and the clozapine?" And I'm going, well, no, but there's an interaction between that clozapine and whether he's smoking and whether he's decreased his smoking. And he went, oh, and I said, yes. And there's this wonderful website that Lisa Wilton put together. Lisa, I hope you're listening. And please, and I showed him all of the resources on it. And I think it is so important that we do. It's great that they stop smoking, but it actually can put their clozapine levels up. So that's the kind of detail that's really good to be aware of. More later.
Brilliant, Jackie. Thank you. All right. So my favourite area, I guess, it's because of the patients, so is the metabolic health. Again, there's some really nice guidelines. I guess I wanted to wave the flag for earlier and more confident prescribing of metformin in your patients. There's a really nice guideline at the link given. You can see it in the green, obviously too hard to read, but really important. Good tip, start your first dose lasting at night because can make them a bit nauseous they're asleep with those early onset of symptoms, and really helpful for sugar control. And there is, because of that subtle effect on a slight sense of nausea, it can pull back appetite a little bit too. So that's quite good for reducing caloric intake in the late part of the night and over the day. So next slide, please. Oh, I've whizzed through them. I've whizzed through them on purpose because I think this sort of talk, and we'll have Jackie's in a minute, I don't want to flog the knowledge. I think the GPs and people here tonight have a lot of knowledge. I wanted to use this as a bit of a backbone on which to hopefully have some really good questions and discussion, and to talk about our case, which is actually quite complex and tricky with these in the reference in the background. I chose the cup of tea because I thought you'd all want a cup of tea and a lie down by now. I certainly did. And I'll hand over to Jackie. Thank you.
I like the idea of the cup of tea. Look, I'm not going to talk for too long, and I may not actually take up the time allotted to me because, frankly, I think you're absolutely right, Michaela. Most GPs have got a pretty good idea of how to manage this kind of stuff. I do just want to highlight some things, and that is that people who've had adverse childhood experiences often have a very low self-esteem and a poor sense of self-compassion because, you know, they've been treated very badly. So for them to come forward and ask for somebody to screen them, I don't know what your experience is, but mine is that often that's way down the bottom of the list for them because it's actually asking for care for themselves. So I think it's worth highlighting that I think you do have to be quite proactive with this group. I think there are barriers. People can feel embarrassed if they're very overweight. That can be a barrier to seeing a doctor in the first place. It can be a barrier to having examinations performed. And I think the more we can invite and encourage and gently show that I don't care if you're overweight. I don't care if we've got this word called obese that we attach to you. What I'm much more interested in is let's get you as healthy as we possibly can. Let's talk about how we can help you to do exercise that you enjoy doing. Let's talk about how we can, sort of support you to do that exercise in a safe way. Let's see what we can do to help you. And I think if we can do that, then, the rest falls into place. The other thing I just want to say, and it's a bit of a random thing about clozapine, but I think we've got a few people floating around from hospitals, and I think it's a useful thing for GPs to be aware of, is the whole thing about when a person goes into hospital and somebody forgets or they don't tell the person in ED or whatever, and nobody realizes they're on clozapine or nobody writes up the clozapine. And then 2 days later, somebody goes, oh, look, they're on clozapine, and puts them back on the full dose. And that's when they're more likely to end up in ICU. Now, we don't always get the opportunity as GPs to kind of intervene, and that it's hard. But if we do find out that a patient's in hospital, and if it's not flagged, it's one of those very useful things that I would consider doing. The other thing is we've got these lovely things called clozapine coordinators, and we've got them at each of the community health teams. If you're getting stuck with it, call for help. They're really good at sorting things out. And that's what I did with that chap that we were seeing. Because, you know, his clozapine levels were going up. He was presenting with side effects, essentially. So I got in touch with the clozapine coordinator at the community health team and said, hey, I've just seen this guy. Can you sort of catch up with him and keep a bit of an eye on him? It worked so beautifully. Linking in with those services is so useful. And, you know, I'm not sure that I want to say an awful lot more, because except that there's some lovely resources. Yes, exactly. As Lisa says, clozapine coordinators are your best friends. This is true. And the other people who are your best friends are the liaison people in mental health services, because, again, often the hardest part is not looking after their health. It's connecting in with the people who are doing the mental health stuff as a GP, and then you telling them about what you're doing and them telling you about what they're doing. And yes, the reforms and all that sort of stuff, but it is so useful when we can work together. Preaching to the converted, because you wouldn't all be here if you didn't feel the same way. I think that's really all I want to say. I think let's move on to the stuff that you know is really going to get the questions going.
Thanks so much, Michaela and Jackie. Really interesting presentation with lots of great links. Thank you.